We are happy that President and Secretary General of Bangladesh Glaucoma Society will be with us in this webinar. And tonight's our esteemed speaker, Professor Iftekher Munir. And we have our Secretary of the Scientific Committee, Dr. Munir Rashidul Hassan, to conduct the program. So I welcome all the delegates, all guests, all panelists in this webinar. And I'll request our delegates, our attendees, to ask any question in the chat box or in the question answer page. So at the end of the presentation of Professor Iftekher Munir, we can give the answer of your question. I will request our panelists, Professor Zakia Sultana Shahid and Professor Siddiqur Rahman, to answer the question and also to take part in the discussion. At the same time, I'd like to thank Aristo Vision for sponsoring this online education platform, BGS Glaucoma. Hopefully, with their contribution, our glaucoma specialists, our residents, our students will be helpful to gain knowledge, not only the basic parts, also the clinical parts in glaucoma. So first of all, I will request our Bangladesh Glaucoma Society President, Professor Zakia Sultana Shahid, to say a few words before beginning of the webinar. Professor Zakia Sultana Shahid, please.
Thank you, respectable Professor M. Nazrul Islam, Advisor Bangladesh Glaucoma Society and Chairman Scientific Subcommittee of Bangladesh Glaucoma Society, for arranging such a nice learning communication between the all the students and all the glaucoma practitioners. Thanks to Rashidul Hassan for arranging this webinar. I must thank Professor Iftekher Munir for taking all the pain for arranging his talk on OCT, which is a very important topic. Thanks. Thanks again for this.
Thank you very much. As our secretary not yet come, so I will request Dr. Rashidul Hassan to introduce our speaker tonight.
Thank you, sir. I welcome you all in the second episode of BGS Glaucoma webinar. And today's topic is role of OCT in glaucoma. And I am very much delighted to introduce our esteemed speaker, my mentor, Professor Iftekher Munir, sir. Let me share my screen. Is my screen visible, sir?
Yes, visible.
Professor Iftekher Munir was a former professor of glaucoma in National Institute of Ophthalmology and Hospital in Dhaka. He is the director cum consultant at Bangladesh Eye Hospital Malibag Limited. He did his glaucoma fellowship from Venu Eye Hospital and Institute in New Delhi, India. He was the former Secretary General of Bangladesh Glaucoma Society. He is the Vice President of Ophthalmological Society of Bangladesh. Professor Iftekher Munir is the author of over 20 national and international scientific publications. And he received award of Professor Mubarak Ali Award in 2014 from Ophthalmological Society of Bangladesh and Professor Saidur Rahman Award in 2018 from Bangladesh Community Ophthalmological Society. In 2024, he also received Asia Pacific Academy of Ophthalmology Distinguished Service Award as a recognition of his work. Now, I would like to request Professor Iftekher Munir, sir, to deliver his talk. Over to you, sir.
Professor Munir, please.
Share your screen, sir. The screen is yours.
Yes. Okay. Then, my screen is visible?
Yes.
Thank you, Dr. Rashid, for your nice word. Assalamu alaikum and good afternoon to everybody. I am Professor Iftekher Munir, Consultant, Bangladesh Eye Hospital, Malibag Limited. Welcome to you today, my topics. Before presentation of my topics, I would like to give thanks Scientific Subcommittee of Bangladesh Glaucoma Society, Mr. Chairman Professor M. Nazrul Islam and Secretary Dr. Rashidul Hassan for initiative this academic activity, and also thanks Professor Zakia Sultana Shahid to the panelist and President of Bangladesh Glaucoma Society and Secretary General Professor Siddiqur Rahman for their kind presence in this webinar as a panelist. Now, I welcome everybody to my presentation, Role of OCT in Glaucoma. I have no financial disclosures. If you diagnose glaucoma, you can treat it early. And if you treat it early, you can slow the rate of progression. If you slow the rate of progression, you prevent the blindness. This is from Robert Winburn, Harvard Medical School. Changing footsteps in glaucoma diagnosis and monitoring. Previously, we diagnosed glaucoma clinically, but with the development of digital science, now the clinician can diagnose and monitor glaucoma with the help of digital science more accurately, more precisely. Which investigation or investigations should we perform for glaucoma diagnosis and monitoring? Visual field, OCT for retinal nerve fiber layer, OCT for ganglionic cell, inner plexiform layer, OCT for ganglionic cell layer. In my presentation, I try to give the answer of these questions. There are two types of OCT or scan pattern in glaucoma, peripapillary and paramacular region. In peripapillary region, where the nerve fiber layer is the thickest. So by peripapillary scanning, we can detect the nerve fiber layer of the retina. And in paramacular region OCT scanning, where the ganglionic cell is the most thickest part. So by the paramacular scanning, we can detect and analyze the ganglionic cell layer. In my presentation, I try to describe what is OCT, how we can interpret the OCT printout, and how we can correlate OCT with the clinical finding. I try to describe this. Optical coherence tomography is a non-invasive imaging tool. It takes the cross-sectional image by light waves, and with a clinician, glaucoma specialist use this OCT for glaucoma diagnosis and monitoring. Now the parapapillary OCT. For peripapillary OCT, there are OCT machines are available in our country, like type domain, spectral domain, and modern sweep source OCT. Difference of the time domain and spectral domain. Time domain is a 6 radial scan, whereas the spectral domain is cubical scan. And the scanning area in the time domain, it is 3.4 millimeter, whereas in the spectral domain, it is 6 millimeter. And the scan speed in the time domain, it is only 400 scan per second, whereas in the spectral domain, it is more than 40,000. And the image resolution in the spectral domain is more good than the time domain OCT. Whereas spectral domain OCT as a time constraint for this presentation, I try to describe the Ceres spectral domain OCT mainly, and to some extent the spectralis OCT. Indication of spectral domain OCT mainly the retinal nerve fiber thickness analysis, optic nerve head analysis, and the anterior segment analysis. And retinal nerve fiber analysis we use for pre-perimetric glaucoma diagnosis and detection of the glaucoma progression. This is the serious OCT printout. Here at the topmost part, we see the particular of the patient and particular of the scan pattern and the signal strength. These are the thickness of the map, deviation map, and tomogram of the optic nerve head of the left eye. And these are the same segments for the right eye. And in between this is the tabulation chart. This is the neuroretinal rim profile. And this is the retinal nerve fiber layer profile. This is the quadrantic, and these are the clock distribution. Let us try to understand each segment separately. This is the general information of the patient and particular of the scan pattern. This is very important imaging reliability. In the serious OCT, there is scoring of the 10. When the scoring of the print is more than 6, it is acceptable. When it is 6 or less than 6, it is unacceptable. Now the normative database, it is a multicentric cross-sectional data, age range from 18 to 80 years, and US FDA approves this database. When the data is within the 1%, it is expressed by red color, and when it is 1 to 5%, it is expressed by yellow color. And when it is 5 to 95%, it is expressed, that is the major range, and it is expressed by the green color. Retinal nerve fiber thickness map. It is actually the quantitative assessment of the retinal nerve fiber layer, and it is expressed by chromatic bar from blue to yellow-red. And normally, we know the upper and lower part of the optic disc nerve fiber is thick, so it is marked by the yellow-red in the upper part and lower part of the optic disc. When we suspect the disc is thinning by glaucoma process, in the right side we see the upper and lower part, it is yellow-red color, that is normal. But on the left side, the upper and lower part, it is blue color. It indicates there is nerve fiber layer here is thinning by the glaucoma process. Now the deviation map, it is the quantitative assessment of the optic nerve within the calculated circle. If there is any nerve fiber layer loss here within the calculating circle, it is indicating by the color code red or yellow. The left side we see in the upper part and lower part is the red yellow color, which indicate in the upper and lower part there is nerve fiber layer, and this red and yellow color indicate the probability layer color code. Now the retinal nerve fiber layer analysis profile. In this profile, we see the patient data compared with the normative database expressed in the banded form in quadrantic sequence, temporal, superior nasal, inferior temporal quadrant. This is the graph. Here we see the comparison, double comparison. One comparison with the patient data. This is the solid line is the right eye data, and dotted line is the left eye data. This data is compared the normative database. And second comparison is the comparison of the left and right data with each other. When we say the retinal nerve fiber layer is normal, when it is double hump, when the data lies throughout the segment within the green band, and when it is overlap with each other. When these three criteria fill up, we say it is normal. Now the question, why it is double hump? We know in the superior and inferior portion of the optic disc, nerve fiber is thick. So in the superior and inferior region, it is hump. This is double hump. Why it is within the green segment throughout this course? Because we know the green segment extend 5 to 95% of the normative database. And why it is overlap with each other, that is left and right data overlap with each other, is because normally left and right data almost symmetrical. This is when we suspect there is nerve fiber layer defect. Here we see the left patient data. This is the dotted line. Here it is segment deviate from green to the yellow-red segment, and there is no double half pattern of the left data, but the right data is double half. So there is no overlapping. So we can say by that the left eye is suffering from glaucoma, and there is a loss of nerve fiber there. This is the side by side. This is normal double half pattern overlap with each other, and here is left patient data indicate the loss of nerve fiber there. This is the tabulation data, average thickness of the nerve fiber layer and asymmetry of the two eye. Here it is expressed by numerical value, or also background color indicate the normal data comparison. And symmetry, we know both eye data is symmetrical, but the glaucoma is a asymmetrical disease. When both eye is affected by glaucoma, there is asymmetry, and this asymmetry is indicate one of the criteria for glaucoma. This is the quadratic distribution, and this is the clocker distribution of the retinal nerve fiber layer. It is accessed by two way, one numerical value, and another is the background normative database color. Here we see on the right side, both left and right within normal, but on the left side, right eye is normal, but the left eye indicate in the quadratic and sectoral region of fiber layer defect. This is the printout of Syrah Society, where we see in the both eye, in the thickness map, there is a gross nerve fiber layer defect. In the deviation map, we also see in the upper and lower portion, there is nerve fiber layer defect, which also similar in the tabulation data. In the retinal nerve fiber layer profile, we see data is almost flat and deviation from green segment to yellow-red segment. And it is also supported by the quadratic and sectoral region. Now the spectralis OCT by Heidelberg Engineering. This is another very popular OCT machine from Germany. Here two type of laser used during the scanning, one for eye movement detection and another for the image taking. As a why, by confocal scanning in the spectralis OCT, we can take the good image. It is a confocal type of scanning by anatomical positioning system. This is one of the technology by which spectralis OCT demarking the Bruchson membrane opening, internal limiting membrane termination, and the landmark of fovea. And spectralis OCT help in glaucoma diagnosis and monitoring by these tools. Bruchman's membrane opening, minimum rim width. This is the actual retinal rim analysis profile. And this is the retinal nerve fiber, that is the peripapillary nerve fiber analysis. And this is posterior pole asymmetrical analysis. And here we see neuroretinal rim is detected by anatomical positioning system. The outer border of the rim is detected by the ending of the Bruchman membrane, and inner border is identified by the ending of the internal limiting membrane. In between this Bruchman membrane and internal limiting, this is the neuroretinal rim, and BMO, minimum rim web spectralis analysis, analyze this and compare with this normative database. Here we see this rim analysis. There the infratemporal position, there is nerve fiber rim defect, and it is also see in the graphic form, and the scanning pattern here we should also see this infratemporal region nerve fiber layer defect. This is the nerve fiber layer analysis by spectralis OCT. On the right side, we see in the upper and lower portion there is a fiber layer defect, but on the left side it is healthy. So when both data is present in the graphical form, we see the right data is deviate to the inferiorly. There is no overlapping with each other. This is one of the printout of a patient. This is the scanning ophthalmoscopy. We see the infratemporal position thinning, and it is supported by the limb defect. And in the posterior pole thickness analysis, we also see in the infratemporal position there is thinning. And this is the posterior pole asymmetrical analysis, where we see the inferior half of the retina is thinning than the superior half, and it is marked by the gray color. Now the paramacular OCT. This is the applied anatomy of the macula ganglionic cell complex. Actually, ganglionic cell is a neuron. Each cell body from the ganglionic cell layer, its dendrite from the internal inner plexiform layer, and the axon, which from the retinal nerve fiber layer. Now the region where vulnerable, the arcuate region nerve fiber are vulnerable as because when it exits the optic nerve head, the lamina cubosa pore are wide and the subbove are less. So in the disc region, arcuate fiber are vulnerable by the intraocular pressure. And among the superior and inferior region, inferior arcuate fiber more vulnerable than the superior region. Now, which statement are for paramacular region is correct? Anatomically, paramacular region are more homogeneous than the parapapillary region. Less number of blood vessels in the paramacular region. It consists of 50% of the retinal ganglionic cell, and it can early diagnose perimetric glaucoma than the retinal nerve fiber there. Actually, these four are correct for the paraganglionic region. This sinus and spectral luminosity in our country very popular. We use this both type of OCT for ganglionic cell analysis. Now, the difference of the sinus and spectral luminosity for ganglionic cell analysis. In terms of macular layer measurement inside serous OCT, it detects the ganglionic cell and inner plexiform layer, but in spectralist OCT, it detects whole retina from Buchmann membrane to internal limiting membrane. In terms of map provide, serous OCT provide thickness map, deviation map, and sectoral map, whereas the spectralist OCT provide the thickness map and asymmetrical analysis map. In terms of bead diameter, in serous OCT, it is 6 by 6 millimeter, whereas in spectralist OCT, it is 8 by 8 millimeter. Now the macular thickness versus ganglionic cell. As the image quality improved by the OCT machine can separate the retinal nerve fiber layer easily. Here the ganglionic cell, we see the ganglionic cell body internal limiting membrane and nerve fiber layer, and whole retinal thickness here we see from Buchmann's membrane to internal limiting membrane. Here now the ganglionic cell complex versus the ganglionic cell analysis. Here we see the ganglionic cell complex, the three-layer ganglionic cell, inner plexiform layer, and nerve fiber layer. It is detected by optoviews, RTViews. This is the machine from United States. But in ganglionic cell analysis, here the ganglionic cell and inner plexiform layer, it is detected by the Carl Zeiss OCT, and whole the retinal layer from Buchmann membrane to internal limiting membrane by spectralist OCT. Now the limitation of the paramacular OCT. In the paramacular OCT, not reliable when there is a macular disorder, and paramacular region consists only the 50% ganglionic cell of the retina. Remaining 50% is outside of this analysis, particularly on the nasal side of the ganglionic cell. It has no representation of the paramacular OCT. Ganglionic cell analysis, ganglionic cell complex it consists of 30% of the retinal thickness. Rest 70% is outside of the paramacular OCT. Now the serous OCT ganglionic cell analysis. Here, this is the printout of the serous OCT ganglionic analysis. Here we see the topmost part, particular of the patient and scanning pattern, and the reliability of the image. And this is the macular scan, and this is the thickness map of the both eye. It is donut shaped and expressed by the chromatic bar from blue to yellow red. This is the 6 sectoral region of the thickness map, and this is the deviation map, the S-mesh deviation of the thickness map here. And this is the tabulation chart, average and minimum thickness of the ganglionic cell and inner pediform layer. Let us see, this is a printout of the serous ganglionic cell analysis. This is the signal strength is acceptable, and in the macular scan, macula is healthy. The thickness map, we see in the infratemporal region, there is thinning, and it is similar finding in the sectoral region. And in the deviation map, we also see there is a wedge-shaped deviation. So it indicate by all segment, we can say there is the retinal ganglionic cell loss. This is another serous OCT ganglionic cell analysis printout, where we see the 360-degree in both eyes, and there is thinning, and it is supported by the sectoral region and deviation map, and also the tabulation data. Now the spectralist OCT Heidelberg Engineering from Germany, the posterior pole analysis. It is the map is about 8 by 8 millimeter. It's expressed is finding by the inter-eye and hemispherical deviation and average thickness of the posterior pole. This is the printout of the spectralist OCT. Here we see the thickness map, and it is expressed by the chromatic bar. It is 8 by 8 millimeter square millimeter area, and it is divided into 64 small square, and its background is also shows the numerical value. This is the inter-eye deviation from right to left eye. Here we see right eye when compared with the left eye, right eye is thin, so it is expressed by the gray color. And the same on the right eye, when it is compared inferior to the superior half, we see the inferior half is thinner than the superior half, so it is expressed by the gray black color. So by ultimately we can say in the right eye, inferiorly ganglionic, inferiorly there is retinal defect, that is why this gray color in the inferior region. But on the left side, it is there is no gray color in any segment, so we can say it is healthy. Now the pros and cons of the ganglionic cell analysis. Advantage pros is the we can diagnose by the ganglionic cell analysis early, and it is reliable for monitoring the glaucoma. But the cons is when there is a macular disorder, the data is non-reliable, and it has no reflection of data from the nasal side. The structure function integration. GIS forum integrate the visual field finding and paramacular and papillary retinal fiber layer integrated by this forum. So the 4 printout, that is the visual field analysis and the retinal fiber analysis or ganglionic cell analysis, we can integrate this central part. Here we see the visual field finding of the right side correspond with the retinal fiber there. Here on the left side also visual field finding, there is a visual defect, and there is infratemporal nerve fiber layer thickness in the OCT and ganglion cell layer infratemporal region. When this is integrated in the central part. We see the visual field finding is integrated with the retinal fiber there. So the clinician can easily correlate the subjective or objective or structure function finding within the central integrated portion, and ultimately he can easily correlate with the clinical findings. So diagnosis can be accurate by this forum. Now the devices for monitoring glaucoma progression, device are fundal photograph, visual field, and OCT. The fundal photograph has no background data, but the visual field and OCT has background data. Visual field is subjective variation, so it varies from subject to subject, but OCT is the objective test and it has strong database. So by OCT we can see and we can monitor the glaucoma very accurately. Now the Zeiss Cyrus HD-OCT, how it can analyze the progression. It is the guided progression analysis software by which Cyrus OCT can judge the progression. Here, the Cyrus OCT need at least three images to and the good quality image, and the quality image, the image should be more than 6. Otherwise, it is unacceptable. And first two images for the baseline evaluation, and third image for the to see the progression. There are two types of guided progression analysis: event analysis and trend analysis. By event analysis, we can see the focal defect, and by the trend analysis, we can see the gross defect. In event analysis, it is point to point and pixel to pixel differentiation from the basal OCT, from the last follow-up OCT. Here we see this is event analysis map. These two are the basal OCT and this is the last follow-up OCT. And when there is any statistical difference between the two, it is indicated by this marking. And in the trend analysis, it is expressed by linear expression, and we see this the follow-up OCT is expressed by this linear graph. This is the event analysis. These are the two basal printout, and the first follow-up and the second follow-up. We see here the first follow-up when the compared with the basal analysis, there is some deviation, but it is not clinically, it is not statistically significant. That is why it is marked by the possible progression. But the second follow-up, there is statistically significant difference, so it is marked by the likely progression. When the clinicians see this likely progression, it becomes careful regarding the patient that glaucoma may be progress of the patient. This is the trend analysis. We already said it is analyzed by the linear progression. Here we see this is a red mark from basal analysis to last follow-up. It is there is nerve fiber loss, so it is marked by this red color. Spectralist OCT, we can also see the progression. This is the initial basal OCT, and this is the follow-up OCT. When we compare this basal OCT with the last OCT, we see basal OCT is healthy. There is no defect, but in the last follow-up, there is this marking indicate the nerve fiber layer loss. So we can say the patient is progressing. In the moderate, mild to moderate glaucoma, we can see the progression by the visual field and parapupillary and paramacular ganglionic cell analysis. But in the severe glaucoma, due to floor effect, we cannot see the progression by OCT. We can see the progression by only the visual field test, that is the 10-do test, 10 and DES2 program. White field OCT deviation map for early glaucoma diagnosis. White field, it is the image of 12 into 9 millimeter. It is about double the spectralist OCT. Spectralist OCT grid is 6 by 6. Here it is 12 by 9, about the double. So it can single scan, we can see the parapupillary and paramacular region, and the printout also here we see, and the same patient, the nerve fiber defect, same patient, ganglionic cell defect, and when white field OCT, we see this white shape nerve fiber layer defect, and here it is also the V shape ganglionic cell layer. So clinician can easily see both parapapillary and paramacular defect by the same printout. So it is modern development of OCT here. Now the artifact. Source of artifact, operators from the operator, patient, and from device. Signals sent on one of the most important thing. If it is less than 6, it can affect the nerve fiber layer. Eye movement, blinking, ocular surface, and ocular media. Small people also affect the image quality. If the patient is not properly enter into the computer OCT machine, and data analysis should not be correct. This is the medial opacity. It is the medial opacity, black, and also the thickness map and the nerve fiber layer is so the medial opacity can affect the quality of the printout. This is the tear film, where we see the lower meniscal tear film can affect the OCT. This is the misidentification of the disc border. When in the high myopia, we know the optic disc is tilted, so OCT machine cannot identify the disc border. This is the blinking effect on the OCT. Now the technology limitations. These limitations are the green disease, red disease, floor effect, and inadequate database. Green defect is when in the mild form of retinal fiber layer defect, OCT cannot detect it, and OCT expects that it is green, it is healthy. But there is mild defect. This is called green defect. Red disease in the high myopia, superior and inferior arcuate fiber are shifted towards the papillomacular bundle. So OCT machine when scan the upper and lower part of the optic disc, and when it compared with the image database, they detect that there is nerve fiber layer defect and patient is suffering from glaucoma. Actually, patient is healthy. So it is called red disease. Floor effect, when nerve fiber thickness is less than 50 micrometer, OCT cannot see the progression. As because this 50 micrometer is considered the blood vessel and glial cell. This is called floor effect. In integrated database, we know the database consists the 18 to 18 years of the patient. So the patient who have less than 18 years and the patient who have more than 80 years age, computer cannot compare his database with the patient age. These are the limitation of the OCT. I already told that the green defect, here we see in the thickness map, there is a small defect here, and in the hemispherical deviation, it's also so this is a defect here. But the nerve fiber layer indicate that there is no defect. So we can express it is a green disease. This side red disease due to more arcuate fiber deviation towards the centrally. This defect is produced by the red disease, and this is the floor effect due to the thickness map less than 50 micron. This is the database. The patient is 13 years age. So normative database, there is no normative database comparison. Now the anterior segment analysis by the OCT. Anterior segment analysis by OCT, by spectral domain, SLOCT, and the SSOCT. The parameter we can see by anterior segment OCT, central corneal thickness, central and peripheral anterior chamber depth, and the angle structure. You can see here the narrow angle by anterior segment OCT. SLOCT, here the OCT is mounted on the slit lamp, so good quality image can be obtained by the SLOCT. This is one of the image of the SLOCT. We can see here in different location of the cornea. We can see the thickness we can see, we can measure the pupillary diameter, we can measure the anterior chamber depth, we can measure the angle with different tools. These are the tools: angle opening, the distance, trabecular iris surface area 500, 750, and it is measured always from the scleral spur region. The sweep source OCT, these are the sectional view, and these are the 3D view. This is the 3D view. We can see the peripheral anterior synechia. We also quantified the bleb area by the anterior segment OCT. This is before and after LPI, anterior chamber and angle structure, and this is before and this is after. And now the advantages and disadvantages of the segment OCT. Anti-segment OCT, it is non-contact and patient in sitting position, so it is patient friendly. It can take easily, and as it is related with the computer, we can reproduce the images. Disadvantage, it cannot identify the ciliary body and retroiridal structures. And for anti-segment OCT, clear cornea is mandatory. Now the patient quizzes. Pre-perimetric glaucoma, where we see the field is okay, but in the OCT there is nerve fiber defect in the infratemporal region. When I see the fundus, we can see there is nerve fiber layer defect, so it is pre-perimetric glaucoma. When the field is normal, how we can proceed? Your field is normal, but in the OCT we see in the superior region nerve fiber defect. When I reassess the red field light, the fundus show in the supratemporal region there is nerve fiber layer defect. When the field is abnormal, you see the field is abnormal. OCT in the left eye, it is the upper temporal portion is also defective, and we see this optic fundal picture. We see there is prominence of the blood vessel, which indicate there is a nerve fiber layer defect. This is one patient, 24-2 field. It is quite healthy, but its OCT show in the superior and inferior region there is nerve fiber layer defect. When this patient, same patient, do the 24-2C program, we know the 24-2C program, the latest program, where within the 10-degree within the center 10 degree, there is additional 10 point for detection the scotoma. When this patient do the 24-2C program, there is the central scotoma we see, which correspond with this OCT finding. The last 4 patient, here we see the visual field sometimes cannot help the clinician for proper diagnosis, but OCT always get the clinician for diagnosis and monitoring glaucoma. Now the pitfalls. Here we see in the ganglionic cell analysis there is abnormal thickness, but when we see the macular scan, it is actually the periretinal membrane. Here in the ganglionic cell analysis, it is like ganglionic cell loss, but when we see the macular scan, it is actually the macular hole. And this papillary OCT, when we see the deviation map and thickness map, there is nerve fiber layer defect. But when we see the optic nerve, it is pale. It is actually the neurological disc. Now changing with time, time domain OCT changing to spectral domain OCT, now the sweep source OCT, better quality of scan, better quality of image, and better wide range of image for which the clinician can easily diagnose glaucoma and easily see the progression of the glaucoma by the improved technology. Now the summary. OCT should not be judged alone. It should take for clinical correlation and judgment. If there is no correlation, clinician should judge for third diagnosis. And anti-segment OCT help in the mechanism of glaucoma identification in addition to clinical examination. When The clinician interpret the glaucoma. He utilize his clinical knowledge for correlation and interpretation of the OCT. Thanks for questions, Harry. And now for the
Thank
question.
you, Professor Iftekher Muhammad Munir, for the very elaborate discussion and presentation on OCT. I think it is really a good discussion, good presentation, and we have learned a lot. And you have told all parts of OCT, including its presentation, its interpretation, and RNFL changes, DCC changes, and different software correlation with structure function. So I think everything has been covered. So our panelist, Professor Siddiq, already joined. Welcome, Professor Siddiq. We have some question to you. First of all, from the panelists, then of course from our delegates, from our attendees. First of all, let me ask one question to you. That you told that you order for the RNFL analysis and also ganglion cell analysis. But do you order all patients suspecting glaucoma, both the RNFL and ganglion cell analysis, or only RNFL analysis, or only GCA? Which one you do? You will suggest.
Thank you for your nice query. Actually, ganglionic cell and nerve fiber layer analysis, these are the structural change. We know ganglionic cell in the paramacular region. When death of the ganglionic cell occurs, it is in the cell body, that is the paramacular region. And when this death extends to the axon, there is a nerve fiber layer. So for early diagnosis, I always advise the paramacular region scan and more late for the retinal nerve fiber layer. And it is dependent upon the clinical position of the patient.
Thank you, thank you. So we should order at least for the ocular hypertension, glaucoma suspect, we always order the ganglion cell analysis to have any idea. Thank you very much. Another query from myself, that you have covered everything. Is there any role of Swifter's OCT for OCT angiogram for the diagnosis of glaucoma?
Thank you for next question.
People are using the Swifter's OCT, and we have the facility to do angiogram. So OCT angiogram, does it help for the diagnosis and prognosis of glaucoma? If so, how it helps?
Actually, angio-OCT in glaucoma diagnosis, we can detect the peripapillary capillary position. If there is in peripapillary capillary loss, we can say patient may suffering from open angle glaucoma. By this way, we indirectly help in diagnosis of POAG. But angio-OCT in angle closure glaucoma, so far I know, and there is no indication here.
Thank you very much. I would request our other panelists, Professors Zakir Sultana Shahid, Professor Siddiq Rahman. If you have any question, then we'll go to the participants.
Sir, may
Okay.
I ask a question?
Yes.
Already, my two questions already you asked about the OCT angiogram and the GCL. So I can add my opinion. In case of the early and doubtful case, that is glaucoma suspect, in that case, we have to do more and more investigations to reduce the doubt. So at this level, GCL must we do, and if possible, is OCT angiogram we must do. Especially the patient is a comorbidity with the diabetes, then we should do it, because in diabetes some sort of edema is there always. So that edema sometimes may mimic the very good RNFL thickness. So GCL analysis and OCT angiogram analysis of the disc. In that case, we can make a different parameter for the diabetic patients with the glaucoma.
True. Thank you. Professor Zakir Sultana Shahid, you wanted to say something?
Yes, Munir, thank you so much. So elaborately, you covered each and every corners of these topics. Now, I have a question. We know that the angle assessment by gonioscopy, it is a gold standard. But what do you think? Which one is better, whether intersegment OCT or gonioscopy?
Thank you for your nice question. Actually, we know anterior segment OCT is a static. It takes the picture of the angle. But gonioscopy, during gonioscopy, we can see the dynamic nature of the angle. We know the angle is not fixed. During pupillary constriction, dilatation, during accommodation, this angle is variable. So the dynamic nature can we only see by the gonioscopy and not by the anterior segment OCT. Anterior segment for documentation and gross assessment, I think.
I think the thing is that two tests, gonioscopy and OCT, is two different things. So it correlates each other. It helps each other, but you cannot replace one. You can replace
Right.
one by one for one. We should do both so that we can correlate each other. We can have your positive diagnosis will help us. And that is the thing should be done. Okay, I think if we have no question, then I'll request Dr. Rashidul Hassan to, you have any question from the audience, from the delegate?
Thank you, sir. I have some question in my hand.
Okay.
First question is, sir, you saw in your presentation you elaborate different type of OCT. One question arrived: which OCT machine is best for diagnosis of glaucoma?
Thank you. It is a good question. Actually, everybody asks it. If I am told that every machine, either it is Ceres or Spectralis or Optibius, NIDAC, or any other form, all OCTs are good with a strong database. I think in our position, we have to see the after-sale service. What is the good after-sale service? This machine is best for me. I think this is the best.
But at the same time, Dr. Munir, the
Yes.
machine is having better scan capacity, more fast scanning. We should
Yeah.
think also that a machine
Yeah, of course.
1
These
lakh
are
scan per second, another machine has 60,000 per second. So which one we should choose? Definitely.
of course. During this
Yes.
time domain is only for 400, spectral
Yes.
domain 40,000, and sweep source it is near about lakh.
More than
1
1
lakh.
lakh. Yes, yes.
So depend upon this, but in the same quality machine and the Spectralis OCT, this ideas of Spectralis, which after sale service? I think so. Otherwise, if there is an after sale service, you can get the proper service from the machine.
True.
Yeah, thank you. Another question, how to interpret OCT in case of juvenile glaucoma patient?
Yes, that is a good question. In the database, we know the data is 18 to 80 years. When the patient juvenile 16 or less than 16, we cannot compare the database. So in this position, we only see the numerical value. By the numerical value, we can detect and we can see the progression of the glaucoma in case of juvenile. Thank you.
Yeah, thank you.
That is whatever Professor Munir is saying, that superior inferior usually thickness is higher, so more than 100 micron, inferior like that. So if we find this 100 micron is decreasing in consecutive OCT, then we can understand there is progression, something like that, right?
Yeah.
Okay.
Another question is, sometimes we saw a patient having visual field is tubular, but OCT is normal. What is your comment about that?
Actually, in the clinical practice, we sometimes saw this sort of opposite effect. It is actually, I think so, the visual field is a subjective test. So when the patient is not properly counseled, the first and second OCT, there is a subjective variation. So the patient may present with the tubular field, but the OCT is the objective test. So there is real position. I think same patient went after counseling, we do the second, third visual field, and visual field, I think, should be improved. In this position, one thing I have to do for the clinician and the visual field and OCT with the same machine, with the same program. So we can see what is the improvement of the patient, and we can solve this problem.
Especially, sir, I can add an example. Just reverse. One patient came in yesterday, is a doctor, and his father is doctor. So he's very worried because the OCT shows totally red line, all the red. That means the very marked thinning of
Loss.
the OCT or RNFL. But visual field is totally normal. Several times she did it. Actually, what happened? She is myopic, -6 almost his power is in both eye. So that is the artifact actually, the limitation of the machine. When the machine reads,
This is the
cannot
red
read
disease,
the
red
RNFL
disease.
for the large
Limitation
large
of the OCT, not machine. All machine will show
all OCT.
OCT because already Professor Munir explained it. In high
Yes,
myopic cases, there is some shifting of the fibers. So it shows red, actually is not much thin. Because of myopia, it is very thin. But actually it's not a glaucoma. So actually it is a very interesting question because sometimes we find a lot of change of color, red color, but patient clinically is not glaucomatous. So what is that? It is actually red disease.
Red.
Either artifact or there is high myopia. So we'll have to do again. If the clinically is fine, we should not go for depend on OCT. We should depend on the clinical findings in these cases. Yes.
Right.
Why OCT in CDR measurement is more than in clinical assessment? When most of the OCT we saw, CDR is raised like 0.8, but clinically we saw like 0.5. Is there
There is a nice question. Actually, I described the anatomical positioning system. There is in the spectralis OCT, or there is the anatomical positioning system. In the spectralis OCT, the outer border of the cup, that is the in the anatomical position, spectralis OCT, it is detected by the ending of the inner plexiform layer, ending. So when we see by our clinical eye, but the OCT determine it by ending of the internal limiting membrane. That is why what we see in naked eye, machine is seen in the another way. So this is the basic difference.
But the conclusion is we should not depend on the machine. If we find in the OCT, the vertical CD ratio is 0.8, but I am getting 0.6. I expect my one, not the machine, because machine does not give the actual result, but I can see binocular the way that it is by Bock lens, that is more acceptable and more reliable. So we should not say that this machine having, as the OCT is saying 0.8, his cupping is 0.8. We should not say. Rather, we should depend on our own clinical judgment. That is.
Thank you. In your talk, you mentioned in floor effect. What is floor effect?
Floor effect actually when the machine, actually when the retinal nerve fiber layer thickness is less than 50 micrometer, it cannot see the progression because the retina has the glial cell blood vessel, and this glial cell and blood vessel thickness is about minimum 50 micrometer. So there is less number of nerve fibers. So in the severe stage of glaucoma, when it is thickness is less than 50 or at least 50, OCT machine cannot see the progression. This is the floor effect. That is why in the severe form of OCT, progression is seen only by the visual field at the time that's true, not by OCT.
Yeah, thank you. Another question, in which stage of glaucoma should we advise OCT RFNA? Is it early stage or late stage or something like that?
In which stage?
In which stage of glaucoma should we advise OCT?
In the mild and moderate glaucoma, we can see the progression by OCT and both visual field.
Actually, can I add one thing? Actually, OCT is helpful for diagnosis and also prognosis. So even in an advanced disease, if you compare the previous changes with the new changes, then you can have the prognosis. So definitely, as Professor Munir say, early glaucoma has most important role and moderate glaucoma. But in the advanced glaucoma, you can see the prognosis. So every time you can do OCT, not for diagnosis, rather for prognosis also. That is very important. So I think we don't have time much. We can take another question if we have important question. Dr. Rashid.
Can I say, is there any reliable factors or parameters how can we say the OCT is reliable or not?
That is, of course, during we interpret the OCT. First of all, we see it is reliable or not. And the topmost position there is the signal strength. When the signal strength is 6 or more than 6, it is acceptable. And when it is 6 or less than 6, it is unreliable. Because signal strength not only affect the quality of the print, it also affect the thickness of the retinal fiber there also.
So I think one thing can I add, Professor Munir?
Yes.
One machine it is 6, but in some other machine maybe within 100. So it is more than 60, more than 50. In some machine it is out of 100. So in that case, it should be more than, like TopCon, I think it is more than in 100.
It's a different
More than
machine has a
60.
different parameter.
So it is
I
just
told
60%.
in the Cyrus OCT.
Hey, yes, sir. Different machine has different parameter. So at least usually 60% should be
So
scored.
even
for a
if
level
so
strike.
we can look to the image. First image is given in the disk image is there.
Yes.
If there are many scratches and horizontal distortion, then we can say this is too much distorted image. Then further analysis will be
Yes,
non-reliable.
that is true. But talking about the signal strength, so each machine have its own parameter. So we'll have to talk on that way. Usually 60% is the score. Another thing is that if the patient is having vitreous opacity, having cataract, having myopia, the signal strength may vary. You can even a patient having good strength, good scan, but patient is having cataract. The signal strength may be 50%. So we'll have to also take this thing. The patient is having these few things or not. This factor, like having vitreous opacity, having cataract, having high myopia, then signal strength may be even less than the normal. So anyway, that Professor Munir is saying that it should be 60% or more, we should accept it. Or Professor Siddiq also saying, is there any crashes or something, scan is not good, definitely you cannot take it. So I think already we have crossed 1 hour. So we'll finish it. Professor Siddiq came later, so I will ask him to say a few words about the webinar, then we'll conclude. Please, Professor Siddiq.
Thank you, sir. Thank you especially. Very, very thanks to Professor Iftekher Mohammad Munir. We learned and recap many things. For long, we are not with the study somebody. And many, many thanks to everybody. We learned many things. And in future, we will continue this glaucoma and we will learn about the glaucoma, inshallah. Thank you, everybody.
Thank you very much. Last of all, let me show a slide that our next webinar will be on 1st July, third webinar, and it will be on visual field analysis, the ultimate tool for glaucoma diagnosis and progression monitoring. Speaker will be Dr. Ruhi Mannan. She is the glaucoma consultant at Bardem General Hospital, Bangladesh. So with that, I'd like to thank all panelists, especially President, Bangladesh Glaucoma Society, Professor Zakir Sultana Shahid, Secretary General, Professor Siddiqur Rahman, Secretary, Scientific Committee, Dr. Rashidul Hassan, and of course, our esteemed speaker tonight, Professor Iftekher Mohammad Munir, for their time and very good discussion on OCT. I will request our delegates, if you have any question, it is already live in the Facebook. You can ask question in the Facebook. Our panelist, our speaker can answer there also in future. So at the end, I must thank Aristovision also for sponsoring this webinar program. And I'm requesting all of you, those are attending, those will attend in the next, will see in future in the Facebook and other videos. Please attend our webinar so that will be encouraged, and our residents, our students will be helpful from this webinar, I think. So again, thanks all of you. And again, lastly, thanks to Bangladesh Glaucoma Society for this wonderful program. Thank you very much.
Thank you.
Thank you.
Thank you.
Thanks to all of you also.
Thank you very much.
And good night.
And good night.